Let's talk about cutout when using proximal femoral nails. Proximal femoral nails are commonly used for unstable pertrochanteric fractures, especially fractures with comminution or reverse obliquity patterns. These nails usually have a cephalomedullary component, such as a lag, screw, or blade, that passes through the femoral neck and into the femoral head. But if the fracture is poorly reduced, the implant is poorly positioned, or the construct is mechanically unstable, one feared complication is cutout. Cutout means that the screw or blade gradually migrates through the weak cancellous bone of the femoral head and eventually exits superiorly or into the joint. This usually happens because the fixation does not have enough stable purchase in the femoral head, or because the fracture collapses in a way that overloads the implant. So how do we reduce the risk of cutout? First, the surgeon needs to understand the fracture geometry. The goal is to restore the best possible alignment and cortical support, especially on the medial side, so the bone and implant can share load. However, in poorly reduced fractures, like varus reductions, the head-neck fragment is tilted downward. This makes body weight pass more off-center, instead of being supported efficiently by the medial cortex and calcar. Because of this, the head-neck fragment behaves like a longer lever. The same body weight now creates a larger bending moment at the fracture and around the cephalic screw or blade. Over time, this can promote progressive varus collapse and push the screw or blade toward the classic pathway of superior cutout. Some studies suggest that the reduction should be compared with the patient's own native anatomy. One study showed that a deviation of around 9 degrees or more from the native femoral neck shaft angle was associated with increased cutout risk.